Hello and welcome to PM Express, and today we are talking about the very, very important issue, the matter of health. Health is life. And we are talking about the NHIS. Now, once upon a time, a dream came to being that every Ghanaian should at least be offered primary health care. It had never happened before, but it came to be. What is it? The NHIS, where you go to the hospital and you shouldn't pay. The issue which happened was that not many of us were able to afford. So there were about 28% of us contributing to the scheme, with 70% of us depending on just a few. It's gotten to the point where the scale can't literally hold it anymore. Around 2009, we got to the bottleneck, where a new policy had to be put in place. But we haven't done that. Now with the new sheriff in town, he's saying that this is it. We need to find extra funding, otherwise the scheme can't go on. Now I'm here to talk to him to find out what policy he has in place, what funding methods he has in place, what he's going to do to check leakages so that this scheme will last beyond our lifetime. Because whatever we do, we need to uphold and keep it. When we come back, I'm talking to the Ombudsman of Ghana's Health, NHIS. My name is Nana Ansakwao IV, Chief of the very little Republic of Akwama Dumasa. Don't go away. We are talking health when I come back. Well, thank you very much for staying. And as you can see, I'm in a very plush office and not the usual studio. Well, I am in the office of Dr. Samuel Ano, who is the Chief of the NHIS. Indeed, we can say he's the new kid on the block, because as you all know, running into the 2016, there was a lot of complaint about debt that had saddled the NHIS. Service providers were really complaining. So here's the man who's been dropped in there, and I'm sure his orders are sink or swim, and I'm sure he wants to swim. Doc, thank you very much.
Thank you so much, Nana.
Yes.
And greetings to your audience.
Great. We normally find first timers. You know, I'm a chief, so I'm Bantamusa. Since you're first time on the show, my viewers are going to find you. I'm Bantamusa. But, well, let's say congratulations.
Thank you, Nana.
And is it tougher inside than it is when you were outside?
It is really tougher inside than outside. Because when you are outside, the solution seems like ABCD. But once you are in, then you come into contact with the public sector and the way things are done, and the way things need to be negotiated and discussed, and the time that it takes. So it makes it a little bit cumbersome and a little bit more time consuming. But I think at the end of the day, it's got to be done. That's the bottom line.
What is it that we were doing that made it work, that now is not working anymore?
Nana, is simple. The decision we took, I'm glad when you made your opening speech, you said it was a dream. It's a dream which still remains a dream, but a dream that needs to be achieved. It needs to be achieved. Universal healthcare has become a right. And it's become a right because in every society, you cannot let those who have the money treat themselves and those who do not have be left alone, because those who have, if they treat themselves and those who don't have are not treated, they will bring the disease back to you. Yeah, so it's a cycle of a web. Health is such that we're all in it together. So it's either all of us swim together or all of us will drown in it. A typical example is the Ebola.
Yeah.
Yes, if you don't treat everybody, you all drown. So that is the reality and the dream that we all, once you are sick, you keep up a card or something, you go to any service provider and they don't ask you questions, they don't ask you pay that, and you are looked after. That's the dream that we have to achieve as a nation.
Doc, you see, I look at the likes of like UK and US who are pulling trillion-dollar GDPs, I mean big GDPs. They have more people on their scheme paying and fewer people just relying on it, and they are struggling.
Yes.
I'm looking at us with a smaller GDP, with more people on the scheme not paying. So how is this holding up?
I must say we've done a lot with the little that we're paying. The UK system, because of their high GDP, they're paying in excess of 1,000 per person per year to be on their national health insurance, and most of them are on their health insurance. But of course, the level of care also varies. It varies. We have what we call the basic primary health care, and that is what we as Ghanaians were targeting. That a certain basic primary health care should be available to everybody. We're not talking about the high-tech thing where if you are coughing, you need sent through a CT scan. We are talking about using our clinicians to pick out why you are coughing and take it step by step, have a basic x-ray and stuff like that. So basic health care, yes, we're doing at about $28 per person per year. We're only beginning. At the moment, that's the kind of funding we have at $28 per person per year. The developed countries are doing over 1,000, but they are high-tech. We want to see how we can cover basic primary health care, and our target is just $100 per person per year. That's the target we need to get. So even at the $28, $30 per person per year, we've achieved some landmarks, which makes it very encouraging for what we are doing. For instance, when we started the scheme, the life expectancy in this country was at about 57 years. That if a child is born, you give the child on the average up to 57 years and you'll be called to glory. With the advent of the National Health Insurance, that life expectancy has increased from 57 to 63 as we say today. So we have chalked some landmarks. The 63 habit is still small. It's very small in terms of what the world trends are doing. Our neighboring Rwanda is doing 70, 71 years as a life expectancy. So 67 was still low. So there's room for improvement. Now, if you come to another indices like maternal mortality, which is a major concern, because our women shouldn't die when a woman falls pregnant. They are young, they are kids. Every system of theirs is very young, it's fresh. And they are the kind of people who fall pregnant. That's why there's a talk so much about people who die as a result of pregnancy. It shouldn't happen. It shouldn't happen. When we started the scheme, we were doing about 650 maternal deaths or so per year, per 100,000. But now we are down to almost half of that. So we are doing well, but we could do much better. We could do much better if we can, all of us take our health as priority number one. I mean, there's nothing more priority than our health.
We would do better. And in most things, we have really struggled with implementation. Yes. It's not NHIS, it's just probably a Ghanaian culture. We struggled with implementation. You seem to have reached a bottleneck where we have to take drastic decisions to move on. Is it one of those things that's just going to remain a talk show on a paper, or is it something that can be actualized?
I think myself, my board, and our executives are determined that this talk show will continue until it is solved. Because as a nation, we don't have a choice. We can't continue to focus on infrastructure and focus on all the things that we are doing without giving priority to our health. Because as a nation, we must know that a healthy society is the best the finance minister will get. It's the best any employer will get. So once our health is taken care of, we're more efficient, our productivity will improve. And in fact, world economists are telling us that when you invest in health, it's one of your best investments. So we'll continue to talk and discuss until we find a solution. Because really, there is a problem, and we need to find a solution to the problem.
Doc, we are hovering around $28 per patient per year.
Yes.
You are hoping that we move to $100 per patient per year. Are you not asking for too much?
Nana, this question you are asking is like you want to eat fufu and abankwai, and your wife tells you it's going to cost you 10 cedis, and you say you have 2 cedis. What do you want your wife to do?
Gary Soki. So that's the cost of it.
That's the cost of it. And I look at our lifestyles, I look at what we spend money on as a nation, and I have no doubt in my mind that it is doable. We just have to accept that health is a priority and it will be doable.
What is the NHIS proposing as a policy to, the state that, look, implement these 1, 2, 3, or 4 measures and give me this money? Are you proposing, or you're waiting for the state to come and tell you something?
No, we're proposing and we're discussing. We're not just taking it to government. We're proposing, hear views from the public, and as Ghanaians, make Ghanaians aware that, well, we took a bold decision and putting aside 2.5% of our VAT and 2.5% of our SNET to look after our health. And members, people were asked to join the National Health Insurance Scheme. It started from 0. It grew up to about 11.5, 11.4 million active members on the scheme, maximum. And we got to a certain level that we realized that this 2.5% VAT and 2.5% SNET was not holding. It held up to about 2009. And then we realized that we had to fall back on the reserves we had. You know, as an insurance scheme, you need about 6 months reserve, because if there should be any catastrophe in the nation and you need a lot of money to look after people, the money should be there. So our reserves started going away from about 2009 when the membership grew up to a certain level. And we got to a point the reserves got finished. Now we started owing, and we owed, beginning of last year, this 1.2 billion we spoke into the nation about. Now it is purely because you need $100, or what the world has defined as $86 per person per year for primary health care. Now,
that's the world average.
That's the world average. It's the recommendation for
okay.
providing basic primary health care for citizens. Okay. You know, healthcare is a commodity. It's an international commodity you purchase. Yeah. If you want to treat typhoid or you want to treat pneumonia, it is the same. It will cost you in Nigeria or Lagos, or for that matter in South Africa or London or US. It's the same thing. It will cost you. You use the same drugs, the same injections, same needles. Everything is the same. So it will cost you about averagely same amount. Okay. So we say that on the average, to provide the basic primary health care, devote about $86. You want slightly better than basic, go to maybe $100 per person per year. That's what as a nation we want to aim at, because we didn't get that. That is why we are in a mess. That is why when you are sick, you go to a service provider, they say this is covered by the insurance, this is not covered, go and pay this. You pass the laboratory, they say pay something. You go for injection room, they say pay something. You go for x-ray, they say pay something. It's a total mess. And because of the mess, everybody is charging any additional money or so that they want to try and survive. We have to regulate the system. We have to have enough funding, and we have to bring sanity and allow everybody to follow the rules and regulations. And the things that we agree with the service providers, let them comply with it. And we should also comply with paying them with the service they provide. And we take away this situation where we've allowed people to charge anything as they want under the auspices of the NHIS hasn't paid us, NHIS is owing us, NHIS doesn't cover this or cover that. All those excuses are because we are not funded enough to provide the care and pay those who provide the care.
Our break-neck point was 2009, as you say. At the time, how many people were on the scheme then?
At that time, we had probably about 9-10 million active members.
What are we hovering now?
We peaked at about 11.4 million, and we start active members, and we started going down to about 9.8 million. Now we started going up again. We're about 10.5, approaching 11 million again. So that is where we are hovering. And the input we are getting from our VAT and SNET contribution from Minister of Finance is about 1.1, 1.2 billion a year. So this is the figure we are seeing averages about $28 per person per year. This is the figure which is grossly inadequate.
But on the ground, and I know we are doing $28 per year, but on the ground, how much are we actually spending? Because it could be that we're doing more or less.
Much more. We're doing much more than that. But the problem with the much more we are doing on our own is that it's not regulated, it's not pulled together, so we are unable to cater for the vulnerable, for the poor, for the unemployed, which are supposed to do so that we can have the effective health care. Because if you go to a funeral or church service, any social gathering, the person you are sitting with, if that person hasn't got health care and you have health care, whatever problem he has and he's not going to hospital with, he can transfer and give it to you. So we have to make sure that we don't just leave people to pay out of their pocket, because then it's only those who can afford that will pay out of their pocket. And those who cannot afford will not pay, but rather focus on spreading their disease.
Is there plans to get more people to pay? Because I remember I've had this conversation before. I don't remember who I interviewed, but the general breakdown was that about 28% were people who actually contributed to the scheme, and the rest were either minors or too destitute, but they all had cards and were, demanding service. Is there any way we can increase it to maybe 50-50?
Yes, Nana, we need to. The law says that every Ghanaian is supposed to be a member of the National Health Insurance Scheme. Now, the law says that because if everybody is on, some can afford, some cannot afford, and those who can afford will pay a bit more to support those who cannot afford. And that is why the law made it so. And the law also went further to define the number of people or the category of people who should not be asked to pay anything. Vis-a-vis children under 18 years, people who have worked their lives and they are 70 years and above, people who fall pregnant, are pregnant women are not supposed to pay, and the big category of indigents, people who earn below a certain income, either by virtue of the work they do doesn't bring enough money, or they are unemployed, or they are handicapped or something. The indigents, they form the greater majority of this category. They are also not supposed to pay anything. So the weight falls on those who have a job, who have some sort of income, and the duty of the National Health Insurance Authority is to make sure that those who have some income, everybody is roped in to pay something. And that's what we intend to do.
You know, if you look at over 18 and our population demography,
Yes.
should we look at it again and probably say, look, maybe every household, only 2 kids will be allowed to go free, have more than 2, you have to support? Because I think over 50% of the population is under 18. Yes,
you're right. In a lot of countries, they have restricted that age bracket where free health is provided to 5 years. To 5 years. So all children under 5 years get basically free health care. They don't contribute anything. And after 5 years, they put in some amount of payment. But in Ghana, because the poverty level is so high, and because so many people are unemployed, I think that was the reason behind the choice of the 18 years. And as the economy improves, more people get employed, I think there might be a merit to drop that age from 18 to probably the average internationally of about 5 years where the free care is provided. But at the moment, I would say let's stick to the 18. Too much unemployment.
People are having children. Too much than we can chew.
No, Nana. If we look at the $100 per person per year, if you have 30 million people on, you end up with probably about what, $3 billion? $3 billion will translate to probably about 12, 15 billion cedis a year. It is doable if we are able to follow some of the recommendations we will put out there for us to follow, which I hope we will have time to discuss. The recommendations will go around the country. We just finished last week with our last region, which was in Eastern region. We just came back to us last weekend. Our interaction, people across the nation. And what we are getting is that it is doable. It is doable.
What are the proposals you put forward in terms of to get extra funding?
Well, we've been working here, we've been around here since we've been appointed by the president for about 9 months now. We have looked at the system and we have realized that there are 4 fundamental pillars that needs to be in place. 4 fundamental pillars. Sometimes when we go through the pillars, we're told that why don't you do this one first and do that one second, do that one third. The bottom line is all 4 needs to be in place for it to be efficient. The first one is the financing model. We're saying that the 2.5% VAT and 2.5% SNIT has outlived its capacity. We need to broaden it. And what measures do we need to use to broaden it? We've spoken about going to government to say that if the people feel that our health is priority number 1, then probably we should increase the VAT of 2.5% to 3.5%. We're not calling for VAT to be increased. All we are saying is that what government has taken, they should give us 3.5 instead of 2.5%. So that is the first proposal. The second proposal is that as beneficiaries of the system, some of us work, some of us earn incomes, others do not. And insurance system works on using the middle and the upper class to try and help sustain the lower, the downtrodden, and the impoverished. So we're saying that let's look at our individual incomes. Let us put maybe 1% on the table. We looked at the people who are contributing SNIT. It's only a very small fraction, and we are using their 2.5% to support the VAT. So, and those group of people belonging to organized labor, if you look at their incomes, it averages about 800 cedis per month. But we're saying let's take 1% of that, which is 8 cedis. Let's try and use that 8 cedis to go to government, to go to the employer, and say that because our health is so important, we have this 8 cedis. Can you match our 8 cedis with 16 cedis or double hours for us? And the government being the biggest employer, now we'll have to look at their wage bill and we are saying our health is important, double it for us, at least put 2% on your wage bill. And if government is able to do that, then we can go to other employers. For people in the informal sector, some earn 10,000, some earn 20, some earn 30 or 50,000. If you earn 50,000, we'll come to you, we say, put your 500 in the health box, and your employer add it up with 1,000. So that with that ACDs that we started with, we can go to the informal sector and say that you put your 1,000 in as an employer, you yourself as a worker, put your 500 in, somebody earning 50,000. So once we can do that, we get a leverage to go to every dictum and Harry who is making some reasonable income and get them to contribute. So this is the biggest proposal we have on, because you are moving from 28 to 100. It's a long jump. But if all of us are committed to it, that formula alone will bring us in probably close to about $1 billion already. And that will immediately increase our 20 ACDs to probably about 40, 50 CDs, $50 per person per year. And then we've looked at also our oil income. And we are saying that let's discuss, and if we agree, put a proposal to government that our health is so important that try and see whether you cannot put maybe about 5% or 4% of our oil revenue into the health basket in an attempt to reach our $100 per person per year. And remember, because the law says all of us should be on, if you work with the figure of maybe about 27 million membership of the National Health Insurance Scheme and use that to do our budgeting and everything. Yes, a few of them might still stay with the private health insurance. Most of the upper class or middle class might stay with the private health insurance because they might want some extra care, more care beyond the primary health care. Maybe some of our workers whose contributions might be significant beyond a certain level might also ask for certain extra care beyond primary health care. So if all this come in, this categorization and things might also come in, but then people then will be asked to pay extra or move into the private health insurance sector. So that's about that. Apart from that, we've also spoken about the health tax, that people who tend to go to a health fund to use it more often, people who drink so much that they are always, their immunity is down and therefore they fall sick frequently and use our health funds more frequently, we say let's tax the alcohol to use it as a disincentive against people who tend to drink too much and therefore use our health funding too much. People who smoke too much, let's use it as a disincentive. Let's tax it. Abuse of sugar has become the most discussed issue on international conferencing now on obesity, overweight, subsequent development of sugar disease or diabetes, and subsequent hypertension. And as a nation, as we talk about the education of it, let us also put a deterrent on overuse of sugar. Let's just put a tax on that also, as we put tax on any other health activity that makes us use more of our health fund. Environmental pollutions, some industrial activities that cause the workers to be more sick, get more respiratory problems. Let's identify all these activities and put a bit of tax on that activity. That if we cannot stop it, then let's put a bit of money from that activity into the health fund or the health box so that when people fall sick, they can resort to that and have free treatment.
Doc, let me take a quick break here. When I come back, I want to find out, in your interaction with the public, with these suggestions that we've put across, which one are you getting the most resistance for? I mean, getting a bit more from the tax, getting a 1% from formal sector, the oil money, informal sector. Where are you getting the most resistance from? Taking a quick break and we'll come back, don't move. Thank you very much for staying, and we are talking to Dr. Samuel Ano, CEO of NHIS, and he's got a lot on his plate and a lot to fix. But just before the break, Doc, I wanted to find out, with your interaction so far with the public, of all the proposals that you put, which ones is easily accepted and which one are they saying, oh, hold on, that's for this one, Doc?
Nana, we've been through all the 10 regions. And the most popular comment is that you're not going around. We gave them 4 foundation pillars that we are saying needs to be fixed to make the scheme sustainable for the next 100 or so many years. Yeah, not fixing it for 8 years or 7 years, but fix it that it will stand the test of time for the next 50 or 100 years. So once they've listened to those foundations, the 4 foundations, then they say, then why don't we resolve the 3 foundations first before we come to increasing the financing model? Because and then if it's an account bill, they'll throw you the typical proverb. The more I quit the so fix the leakages, fix all the things you want to do to make sure the thing is sustainable, and then come to us and then let us look at the financing model. That's been, they say no, paying the ACDs is not the problem, but we don't want to pay the ACDs and then it goes wasted. So all the wastage problem that you've identified, you've told us about brilliant idea to sort them out, do those first before we bring the ACDs. But then we are saying that, so the general feeling is not like our health is not important, or we're not prepared to put ACDs for our health. They say, no, ACDs is not the big issue. But the big issue is the accountability. The big issue is how optimum are you using my ACDs? And if my employer asks 16 CDs, how optimum are you going to use it? So this has been the commonest comment along the line. So maybe if we go through the ones they want us to fix
yes, that's
first.
what I was going to say. What are the 4 main things you've identified?
Yes. The 4 things. The first one, obviously, is the financing model that we are discussing. Okay. And they say, look at the 3. The 3, one of the single most important of the 3 is the fact that as we're set today, we receive claims from our service providers. And now we are supposed to vet those claims and check whether what the service providers are demanding is authentic, not authentic, according to the agreement we have together, or it's not in agreement with what we have agreed on as a scheme and the service providers. So that process happens manually.
Wow. All the 11 million people.
We receive about 30 million claims a year, and about 90% of this are processed manually. On the service provider side, they bring it in boxes of paper to us, and we put all this together and employ people to go through it manually and take decisions and input it back onto a computer system to see whether we should pay or not pay. Now, it's so cumbersome, it's so subject itself to possible abuse and what have you, because you would understand when you do manual, a lot of human intervention. Human beings, we're not angels. You have people, they are brothers, they are sisters, they are cousins, people calling them, do my first, do that, do that. Mm-hmm. In a modern health insurance scheme, anywhere in the world, this is not done. It's all supposed to be done electronic. You take all the human interface from the service provider. They don't bring any paper to you. They communicate with you electronically. And then electronically, you vet what you are saying. Is this a member? Yes, it's a member. You want to see him. What's the problem? This is the problem. Would you pay for it? Yes. How much? This much. Are you admitting? Yes. Admitting for how many days? Are you operating? Yes. What operation? How much will it cost? All these are discussed electronically. And then once it is firmed up, the bill is agreed, they continue to provide the service. And as soon as they finish, within about 48, 72 hours, we know how much our obligations are, and they also know how much you expect. So by month end, you wire their money to them. So we need to move away from the manual process because it takes time. Sometimes when we say we owe service providers about a year, or some people say a year, it looks too bad. But once you use manual processing, the service providers themselves have 3 months to prepare the paper and everything, or the people they have seen, to submit a claim to you. And we as a scheme also have 3 months to go through the paperwork and decide to pay or not to pay or what. So when you put the 2 together, you immediately have about 6 months, which is accepted as a normal delay period. Okay. It's only when it goes beyond the 6 months, 8 months, 1 year, 1.5 years, 2 years, then you know that there's a problem. Okay. Even the 6 months is totally unacceptable. Totally unacceptable. We should have an agreement within a week if it is admission, and admission is less than a week. If it is a single day OPD work, within 24 hours, we should know how much our liabilities are. And if it is beginning of the month, by end of the month, we should be paying.
So basically, until 3 months, you don't know how much, what bill they're going to present to you.
As I said today, I could not have received those probably in October last year, or sometimes even September last year. There's so much delay. When we came in last year, 2017, they were bringing bills way back as 2014, some 2015, some 2016. But because we owe them so much, We couldn't even enforce the law that this thing is gone beyond 3 months and we are not paying. Because the minute they're going to tell you 3 months you're not paying, the one I brought you a year ago, even you haven't paid. So it became a problem. So we have to solve that. But in solving that, when they tell me that go and solve that one first before we pay our money, then they forget the problem that when you solve the vetting problem, the electronic vetting, as soon as you go electronic, within 24 hours, you know your liability, and the service provider wants payment. So if the money issue is not solved, how do you pay? And if you don't pay, your IT system will immediately start giving you problems. You start immediately having problems. So yes, we should solve the verification, everything, move from manual to electronic, but then the money must be there for the electronic also to work properly. The third thing that we are discussing, in every insurance scheme, you need what, for purposes of simplifying it, you need what we call an internal police force. Okay. Because you're dealing with human beings and we're not angels. People will want to take advantage of the situation if certain measures are not in place. Here we call them the quality assurance unit, but the actual work is police force. They take information from whistleblowers, they look at the payment, pattern of payment, and see suspicious patterns and follow the pattern, see whether people are doing things which are irregular. And once they do that and they are convinced that something is being irregular, they're supposed to bring this person before the court of law. Okay. But if that unit is not strengthened, or their morality and everything looked at and made efficient, you're sitting with a situation where so many things can go wrong, so many things. At the moment, what we have need to be strengthened. But what make them a bit inefficient is more of the law that gives them the strength or the backing to work. Because you know our police force, the only reason why when a policeman stands in front of me when I'm driving and he puts his hand up, the only reason why I'll stop is because of the law. Because if I don't stop, he will take me through certain consequences, and I might not like that, so I will stop. Now, assuming that our internal police force spend about 6 months to a year investigating a case of maybe a fraudulent claim, and they are able to confirm with all they have done that yes, this person, this service provider, or this staff is doing something which is wrong, they have to take whatever their findings are to the police. The police will prepare a docket, send it to the Attorney General. Attorney General will bring this culprit to court. And that is where we get our problem. Because you find this case will be adjourned for sometimes 6, 7 years. And then eventually when verdict is given, the law is such that it treats every sort of crime as crime. So if you perpetuate a crime of maybe 20,000 cedis or 40,000 cedis against the National Health Insurance Authority, it could be equated as crime as somebody going out there to steal a piece of banana because he's hungry. And then the law will say that once you are convicted of crime, maybe the judge could fine you maybe 250 penalty units or imprison you for 6 months or so, or maybe both. But because none of them is so loose and so free, you find a lot of our judges will tell the person to pay the amount they owe us, because if somebody steals 5,000, over the 5, 6 years, we might spend maybe about 10 or 15,000 by the time judgment comes. Because each time our people have to go to court, we have to pay them a per diem allowance, because the labor rules. We've got to pay for their transportation, pay their hotel bills, pay witnesses. Anytime witnesses go to court, we have to give them some money. So if they go and the case is not heard, it's not their baby. Next time they come to court again, we have to pay. So you pay all this over 6, 7 years, and the person is just asked to refund the money he stole and cautioned. So we are put on the table that let us look at the punishment under the law, that if you perpetuate crime against the National Health Insurance Authority, it should be treated as a special type of crime, and then set a minimum prison sentence, maybe 2 years, and then say that the amount of money which you are convicted of, you pay probably 10 times that. If the judge decides to make it 20 times or make the imprisonment more than 2 years, make it 10 years, well, that is within his own ambit. But certain minimum sentencing should be enforced by law when it comes to our health. We're not talking for all other forms of crime. We want to isolate health crime as a priority and as an area which is no-go area for anybody. And that's what happens in most countries.
Just manslaughter, isn't it?
Yes.
Technical manslaughter.
Yes, I agree with you. And that is precisely the reason why in most countries, they isolate crime against health as a different type of crime. A different type of crime. And then the reason why we have to do that, it is very difficult also to investigate crime in the health industry. Because usually it's a crime perpetrated between two people alone. And if the two of them don't talk, it's not very easy to unearth that crime. So the only thing that stops them is if there's an environment of fear, an environment that this is serious, this you cannot do. It's like a driver. The only reason why a driver will take care of the pedestrian is he knows that if I knock the person down, big trouble. If that fear was not there, and the driver knew that if I knock you down by the roadside, I'll be fined 2,000 cedis and asked to go home and cautioned, they will knock everybody down. It's the same thing with our law now. So we have to give our health fund a priority that if you commit crime against it, in some countries, once you commit crime against the health industry, the last time we were in Korea, somebody we had seen earlier on had committed suicide. And turned out that they were investigating crime he had committed against the health insurance. So it was better for him to commit a suicide than to wait for the consequences of being found guilty of having committed crime to the insurance. That's how serious they take it. So we have to move away from treating crime against our health fund as any other crime. That's what we are calling on the nation to do. People's comments, people's acceptance of this, our parliamentarians will hear it. We've taken the necessary legal changes. We'll send the information to our health minister. They will look at it, forward it to Parliament. Parliament will also have to look at it. We want the public to be aware, add their voice to it, and as a nation, let all of us agree that crime against our health fund should be treated differently. So that is one of the big things out there also. Then, once we are able to sort out the law and make crime very punishable, and then sort out our internal police force, because they are backed by a very powerful law, and everybody is so much involved in our healthcare that everybody is watching, it strengthens them. It strengthens them. And some of the issues we've also put out there as Ghanaians, we don't feel part of our own health insurance scheme. We want the people, the citizens of the country, to own the health scheme. Be interested in how much is coming. Be interested in how it is spent. We post these things at the end of the year at our website, but very few people are interested. Okay, so let's own the scheme. Let's depoliticize the scheme. Some of the things also which is being discussed out there hugely as we've gone around, that a lot of Ghanaians also believe that politicizing the scheme is a problem. And I tend to agree with them, having reasoned with them and everything. If this scheme is to be sustainable for the next 50, 100 years, we have to completely depoliticize it. And I agree with the comment from organized labor, labor unions, and all the people we have interacted with. It's a big issue. Let's depoliticize. Anything in the law which enables the scheme to be politicized, let's look at it again. And as a nation, let's debate.
I mean, how would you be able to convince people, you know, even though you said 8 CDs is not my problem, but fix it before I give you the 8 CDs. I mean, you come in to say, look, don't worry, you give me the 8 CDs and I'll fix it. Not because of you, but because of track record.
Yes.
We don't trust our systems.
Yes.
How are we going to get over this hurdle? That, look, you give me the money, I'll solve this issue.
Nana, I'm glad you're emphasizing on this issue, because I think people are taking it out of context. If you give me the 8 CDs and you do not help me to fix the 3 other foundation pillars, it will not work. We need all 4 of them for the system to work. And that's what we are saying. So the law should be changed in trying to fulfill all the things we have talked about. The way of verifying the claim should be changed. Because even if you give me the 8 CDs and we do not change a way of taking the claims and auditing the claims and paying the claims, we do not change it, we cannot use the 8 CDs. Because we have to wait 6 months to do the vetting, and your 8 CDs will be sitting down idle. We can't change it. So all the 4 things need to work together. We need to achieve all 4. So let us not isolate only the financing model, because if you do the financing alone and you don't do the other 3, it will not work. And if you do the other 3 and you don't do the financing model also, it will not work. We need to concurrently address all 4 of them.
Wow. You have a huge task. You have a huge task. Let's go with some of the administrative challenges. Yes. Those who say, oh, I was going to go and register, but we don't have any cards. I mean, yes. What's happening with that?
Yes, that has been also huge going around. It's been a huge complaint. Apart from what you have said, that they will say that there is no ribbon, there's no card, there's no that. The big issue is also the time that they waste at our district offices. So you realize that majority of the 8 million members we have are more of the downtrodden, the impoverished. You don't have people within the middle and upper class. You don't have a lot of them on our scheme, because a lot of those would not find 6 hours to go and sit waiting to renew their membership or waiting to get a new card and all that. So we looked at that, and all that is going to be now done by mobile phone application. Okay, so that's always a good news once the public hears that. The second thing about the shortages has become more this year, because moving forward, we are going to integrate with the Ghana card, which is coming under the National Identification Authority. Now, once the Ghana card comes, we will not use our National Health Insurance card together with the Ghana card. Once any citizen obtains the Ghana card, we will put their National Health Insurance card on the Ghana card. And once that is there, then they can activate or renew or do everything by the mobile phone application, and ours will fall back. The Ghana card, we were expecting it to have come into view, or they should have started rolling out by end of last year. It hasn't happened. We're hoping that by about April, May, it will come on. Now, so when we are buying logistics, we are minded by that. We do not want to go to tender and procure for a whole year or two, knowing very well that this can come on at any time, and then we'll find a lot of printers we can't use, ribbons we cannot use, so many things we cannot use, and become a waste. So we procure maybe 3 months, and then maybe it might finish, and then procure again. So that maybe brings shortages, maybe a week, and then we refill. Maybe 10 days, 3 days. Last week there was complaint, it was finished. There was a bit of delay. By end of last week, we have supplied the whole system. So it is running now. It might last maybe in the next 2-3 weeks, and before it lapses, we'll bring some. So this has been the little challenges. But otherwise, the numbers are still going up. Notwithstanding the challenges, the membership has started growing from when it dipped to 9.8. It's still going up. So this is the thing. In a few months, that challenge will not be there, because then NHIS will not be dealing with membership renewals and getting new membership. It will all be done online through the Ghana card. So it takes a lot of load off. So all those things are being looked at.
The other thing is, are you looking at packaging it so that the middle and upper class also have a certain level of usage? Look, I want to go to, this posh clinic, and I want to go via your card. So instead of 28 cedis a year, look, I'm paying 100 cedis a year or 200 cedis a year, but I want this service. Has that been
Yes.
looked at?
Now, one of the major complaints from the service providers has been the tariff structure that we are using and the pricing structures that we are using that we normally negotiate. Of course, it's based on negotiation, but we are also minded when we are negotiating with the budget we have. Okay, we are also minded by that. So they also look at what we have negotiated and also look at the quality or the quantum of service they provide accordingly. So in certain service providers, if the funding improves and the tariff structures are adjusted to make it more reasonable, you find a lot of the facilities who are not even accrediting with us will come and accredit with us. That's the first one. The second one is also been a common comment from organized labor as we are going on, that you asking us to put in maybe 1%. I probably earn about 3,000 cedis. In that case, I'm going to put in my 30 cedis every month. What kind of extra care or extra thing do I get?
Doc, let me take a quick break here, because that's one thing which I think is going to be a big debate. That 1% from organized labor or formal sector. Because we are overburdened with taxes, there seems to be a small percentage of formal sector, and any time government wants to do anything, you just beeline for the formal sector, you pay more. Once we're going to pay this extra 1%, what do we get from it? We're coming back. Well, thank you very much for staying, and we are looking at the formal sector, probably you and I, who get a monthly wage, paying 1% of our wages towards, the NHIS. Doc, would it put me in a different league, or is just 1% that I'm putting in the pot for the,
Nana, we are at the discussion stage. We've reached a certain phase in the scheme that we're all discussing to move it forward. We've had a lot of comments from people who say that, yes, if we are going to put also our funding in to help fund the poor and impoverished, what will be in it for us? And basically, in most countries, what we have is sometimes levels of care. For instance, somebody wants breast surgery, maybe breast enhancement, or wants to do plastic surgery of some kind, which for that person is a serious problem. Okay. That person is paying additional funding. Will it be able to care for that? What we are saying is that beyond a certain level of care, maybe the private health insurance will start kicking in. But on the basic health care that we are doing, the only thing that could be in, at the moment, we do not cover certain types of cancer. These will be brought in. We do not cover certain types of radiotherapy, maybe dialysis, and some of not hugely costly medical care, but averagely costly could be brought on board. So that those people at the high end will be able to have all this cover basically free at the receiving end. So that would be a good thing. But the comment also about we trying to push all the load on the formal sector. I must say that the formal sector constitutes probably less than 20% of the workforce. Over 70% of the workforce are in the informal sector. So there's no way this scheme will be sustainable without us looking at the formal sector. And this is one of the basic reasons also why we're talking about this 1% employer-employee 2% thing. Because then it gives us some tool to approach the informal sector. As we said today, about 95% of the money we are using is still from the 2.5% VAT and Senate. Contributions from members and that is about 3%. It's very, very minimal. It's nothing to write home about. So if you even go to the informal sector, what are you going to get from them? You're going to get just about 2-3% of what you are using. It's not much. That is why we want the whole formula to be changed. And the formula will empower us when we spend the time, the effort to approach the private sector, the informal sector, then there is something more worth the effort that we will put in. So they will all be roped in. And the good news also is that once the Ghana card gets rolled out, it becomes very easy to identify every Dick, Tom, and Harry. Because immediately following that, we expect a cashless society to follow.
So would that, because at the moment I know if I come from Togo, if I come from Ivory Coast, I can come and pay, get my NHIS card and go on the scheme. So when the Ghana card comes, that eliminates that?
It makes the differentiation very easy, because the Ghana card was still put on foreigners who are in the country, but it will make a distinction between citizens and foreigners.
Okay.
The foreigners will still have to pay for their health insurance scheme because, as I have said, because of cross-infection and the fact that when you live together, you cannot take care of one and leave the other. The foreigners in our country will also have to be taken care, their health needs to be taken care of. So we'll make provision for them and their payment will also come on. So they'll also have to pay and will have to take care of. But it becomes easier for them also to contribute either by mobile phone application, their details will be available on the Ghana card, it will be easy to contact them, and it becomes easier in terms of collecting revenue for the National Health Insurance Scheme.
What's the time? What time scale are you looking at? These are.
We're looking at things where by July, these fundamental pillars that we are talking about should be in place by end of the year, or we should start the processes to make sure that it's rolling out. We know they're moving from manual to electronic vetting and processing of the claim. It takes about 1.5 years. But it's a percentage. If you're doing 10% now, if by close of the year you've been able to do 50%, first quarter next year you do 70%, then we're on the right track. So it's a gradual process. And then bringing everybody on board also with the advent of the Ghana card. Now we have memberships in about 10.5 million. Probably by end of the year we might be maybe 15 million or maybe 18 million. By end of 2019, probably will be a full quantum, maybe 27 million or so.
Look, lastly, before my director takes his time from me, it's a product you have. What are you doing to package to make it attractive? Because at the moment, as soon as you say, oh, there's a lot of there's a lot of negativity. What are you going to do to make it more? Oh, NHIS, you have to get on it. It's really good. What are you doing about that?
We're being stepwise. The first thing is to restore confidence in our service providers and trying to clear the areas and pay on time. So that is more or less on track, except 2 areas where, because we want to change the model of receiving their claims and paying them. I'm referring to the CHIP compounds, the health centers, maternity homes. We're collaborating with Ghana Health Service to change the way we receive their claims and then we pay them. That has been finalized. So within the next week or 2, their payments will be sorted out. When that is finalized, there are a few districts where their claims also normally come straight to our center here, our finance department, for them to pay without going through our center processing centers. Now, those ones will have to be rerouted through them. We've taken a decision to reroute through them because the vetting is inadequate when it is done in the district. So we want them to route it through our CPCs. And once that is done, they are also behind because of this transitioning period. Once you bring them on board, then virtually all service providers, in terms of their claim arrears, will be at the same level where they are happy. Because going out across the country, those who are not in these 2 categories are very happy, and they are prepared to stop all unauthorized payments they collect from patients. And if that comes on, so once we sort out the payments, the next thing nationwide we want to do is that all services below the tertiary care, below Kolebu, Komfo-Anokye, Tamale Teaching Hospital, Cape Coast Teaching Hospital, all the teaching hospitals and the tertiary institutions, any care below that, will make sure when you go out there, it should be free. If the care is so serious, so expensive, then you need to be referred to a tertiary center. So that will more or less be able to get it in place by the end of the year. To give confidence to the service providers, start giving confidence to our members and the nation as a whole. And if by then we have started sorting the fundamental pillars so that we don't start going back in our arrears, then I think the confidence will come up and members will have more confidence in terms of contributing whatever we expect them to do.
Thank you very much, Dr. Samuel Ano, CEO of NHIS, new sheriff in town, revolutionaries to change the system. But I think from the conversation, you know that the time has come for us to find new funding, whether we're going to pay, whether we are going to conjure it, however it is, we have to find new funding for NHIS to move on. And I like the way he's saying 100 years and 200 years. We normally think within 4 years, but that's too short. 200 years, 100 years. If NHIS is going to stand, we need to find the money for it. Doc, thank you very much for your time. It's been educative. Folks, we'll be back to do this all over again. Thank you very much for watching.